Hello, my name is Doeun. I am grateful to have a chance to present my research. I'm presenting my research titled Collaborative School Mental Health System, Leveraging a Conversational Agent for Enhancing Children's Executive Function. This research is a collaboration between the SIGCHI lab at Yonsei University and the Department of Pediatric Psychiatry at Yonsei University, School of Medicine. I'd like to present my talk in the following order. A brief description of the study. We developed a conversational agent that helps children start unfinished targeted daily tasks. The agent for me helps children goal, plan, do, and check tasks. We developed a monitoring app for parents and a management webpage for teachers. With these, we propose a system that can work together at home and at school to support children's mental health. In this study, we describe a real-life case study with a first-grade child. Now let me tell you more. ADHD is estimated to affect about 5% of people worldwide. It is the most common mental disorder in people under the age of 19. ADHD is characterized by deficits in executive function. Executive function is the ability to maintain appropriate problem-solving mechanisms to achieve future goals. This is an important skill to have, even if you don't have ADHD. Executive function involves the frontal lobe, a part of the brain, develops through adolescence, but is most heavily developed in early childhood, through the lower elementary grades. Two things are important for executive function development. The first is that the child must be able to regulate their own activities. The second is that it requires repetition and familiarity. We developed our prototype with these two things. Schools are an important place to prevent and help with mental health issues. Because teachers see a lot of children, so they can recognize children with ADHD. But parents may not know because they only care for their own children. However, it's hard for teachers to recommend a diagnosis of ADHD to parents. But schools can play a very important role in increasing access to mental health programs in terms of implementing prototypes or screening. Because if the intervention is applied to all children, it reduces the idea that some children are singled out. So, we didn't target specific children in this study, but rather invited everyone who wanted to participate in the study to use the prototype. In this study, we developed each tool for children, parents, and teachers. It became a system to help children at home and school. The aim of this system is to enhance the executive function in children. Now I'll explain them one by one. We've developed a conversational agent for children. Here's a video to explain how it works.
잘 먹었습니다.
도훈아, 지금 입안이 까끌까끌하지 않아? 저녁 먹고 나서 우리 뭘 하기로 했더라? 뽀미에게 알려줘.
양치질.
딩동댕, 양치질 하러 가자. 약속한 것처럼 3분 동안 하는 거야. 준비됐으면 준비 완료라고 말해줘.
준비 완료.
치카치카 안쪽이까지 해야 하는 거 너도 알고 있지? 그러면 뽀미가 지금부터 3분 잴 거야. 그럼 시작하자. 우와, 벌써 3분이나 지났어. 치카치카 깨끗하게 했는지 뽀미에게 말해줘.
깨끗하게 했어.
도훈이 이가 반짝반짝하네. 양치질 오늘도 잘 해냈으니까 나는 오늘도 깨끗하게 양치질했어. 라고 해봐.
나는 오늘도 깨끗하게 양치질 했어.
그래 맞아. 뽀미도 너가 깨끗하게 양치질 한 것 같아. 우리 내일도 또 이야기하자.
We applied ADHD treatment methods to the child's interaction with the conversational agent. We used the self-instruction step, which is equivalent to cognitive behavior therapy. First, the child and parent decide on 3 daily tasks to perform. Next, the child remembers to do the tasks at the time they are supposed to do them. When it's time to do the task, the agent sounds a notification and calls the child to do the task. The child performs the task. Finally, the child checks off what they've done. We also use behavioral therapy, which is a token economy approach, which means that every time the child does a task, we give them a star sticker to encourage their behavior. In this study, we had 18 daily tasks, such as brushing their teeth for 3 minutes, waking up in the morning. Our study was designed for first graders, so we set up 3 daily appointments per day, considering their developmental level. To help the child perform at home, we developed a monitoring app for parents to use. They can see which appointments their child has fulfilled. They can also see which appointments they're doing well on. To respect children's autonomy, we configured the app so that there are no real-time alarms. The management tool for teachers is organized as a web page. Teachers can see how their class is performing on their appointments. We received IRB approval from Severance Hospital to conduct the study. The study was designed as a randomized controlled trial, with a parallel design. 20 schools in South Korea were recruited. The schools were matched based on the number of students and randomized into experimental group and control group. The experimental group used the prototype for 6 weeks, and the control group had no intervention, so we surveyed them at week 0 and week 6 after they agreed to participate in the study. If the control group wanted to, they could start using the prototype at week 6. The participants in this study were first grade children and their parents. There were 2 exclusion conditions. Children with mental illnesses other than ADHD were excluded, and children participating in other clinical studies were excluded. So, the inclusion criteria were not strict. We measured the efficacy of the prototype in this study in 2 ways. First, executive function was measured with the behavior rating inventory of executive function. The brief consists of 8 constructs and is scored with the Behavioral Regulation Index and Metacognition Index. ADHD symptoms were measured by the ADHD rating scale, which is available for inattention and hyperactivity impulsivity. I'll explain how to analyze the comparison between the 2 groups. After homogeneity for both groups, we analyzed them with repeated measures analysis of variance, or generalized estimating equation, depending on whether normality was met. Then we further analyzed the intervention group, using the prototype. We were curious about the effectiveness of the intervention on ADHD children in the intervention group. We analyzed the data using paired t-test or Wilcoxon signed ranks test, depending on whether normality was met. 20 elementary schools participated in the study, with a total of 179 pairs of children and parents who agreed to participate. 132 of these pairs completed the study, and we analyzed them. We did a homogeneity test to see if there were any differences between the 2 groups, and as the table shows, the 2 groups were not different. The reliability of each construct was checked with Cronbach's alpha. Since the normality test was not met, we analyzed with G. The results are shown in the following table. I'll show the table as a graph. The intervention group scores are decreasing, while the control group scores are increasing. In particular, there is an interaction effect between the intervention group and the control group on the Behavioral Regulation Index and Global Executive Composite among executive functions. Let's talk about ADHD symptoms. On the left, the parents' ratings, and on the right, the teachers' ratings. In the left graph, the increase in the control group is much larger. In the right graph, the intervention group decreased while the control group increased. In particular, in the right graph, we see interaction effects in both inattention and hyperactivity impulsive. This means that there was a difference between the 2 groups. We further analyzed the intervention group. Based on the ADHD rating scale for Korean children, a score of 19 or more by parents and 17 or more by teachers is suspected of ADHD. 2 out of 67 children were screened by parental criteria and 10 by teacher criteria. We analyzed the teachers' and parents' ratings of one child, and they were very different, as shown in the table, meaning that even if the same child is analyzed using the same scale, very different results can be obtained. As shown in the table, we found that the difference in ADHD symptoms from before to after using the prototype, as measured by the teacher, was significantly improved. At the end of the study, we asked parents and teachers for feedback on the Fermi prototype. Parents were impressed with the effort the children made to keep their appointments. Teachers were able to see how the children were doing at home. Some children didn't need the program. Some teachers didn't think it was necessary to know what the children were doing at home. However, I would argue that the benefits of the program outweighed these issues. We believe there is a need for a mental health support system that involves schools. First, parents' and teachers' assessments of children are very different, and teachers can play a large role in identifying children with potential difficulties. Second, it is possible to build a system that can be offered to everyone without fear of bias. Selecting only some children as participants can create a negative perception of them. Next, let's talk about improving children's functioning through conversational agents. Recently, conversational agents have been increasingly used in therapy for children with neurodevelopmental disorders. We've seen improvements in executive functioning and reduced ADHD symptoms in children using Fermi agent. This study has several limitations. First, the exact mental health status of the children was unknown, as they were only screened and not diagnosed. Second, many participants dropped out of the study because the study was not conducted face-to-face and had a high degree of freedom. Finally, we only heard from parents and teachers, not children's experiences. For the next study, we would like to conduct an RCT with a robust design. But our research is meaningful. First, it was possible to see how teachers and parents responded differently to children's ADHD evaluations. Based on these differences, we argue that there is a definite need for a new mental health support system that involves schools. Second, this study confirmed that the conversational agent was effective not only for children suspected of having ADHD, but also for those who are not. Children's improved executive function and healthy routines built in their daily lives are expected to have a positive impact on their lives. Third, the empirical findings provide a positive impression of the field of education and mental health studies using new technologies. In collaboration with the Office of Education, we were able to introduce a system that targets a large population of children. Overall, this study strengthens the notion that technology can enrich children's lives. Ultimately, we aim to argue for the substantial involvement of schools and families in creating school mental health systems for children. In future research, we plan to seek robust evidence to strengthen these claims. Thank you for listening. If you have any questions, please feel free to send them to this email address. Thank you.